All right, so we're here once again with Dr. Sven Friele, our great research fellow from Bochum. I'm Amir Abdul-Jabbar, part of the team here at Swedish Neuroscience. And we are fortunate to have the team with the M6 here with us who go through a cervical disc arthroplasty. Sven's going to help me with the rest of the implementation of the actual device, but we'll just talk you through a few things. So give us about 10 degrees of caudocephalo there. So we just kind of went through the primary process. It's basically exactly the same as an ACDF, really a full release anteriorly, all the way out to the uncovertebral joints of both sides. And making sure we get a very nice discectomy. We also, this patient did have pretty significant posterior osteophytes. And so we made sure to take them all the way down out to the exiting nerve roots bilaterally. If you could take it off mag, that'll give us a little bit better idea. And we are not exactly lined up perfectly there with our pins, but this can give you a reference point as to where midline is. So we're off to one side just a little bit, and we just want to keep that in mind when we're doing our trialing, as well as when we place the cutting guide for the fins that will go in. So come over to a lateral, please. Go ahead to that other side if you want. And I don't know if we can actually see the disc space with the camera here. So ACDF approach, always a kind of challenging visualization for anyone but the operating surgeon. So yeah, we need to be on this camera. All right, so we're just going to show you guys the disc space here, and do need some light in there. So one of the things that we do always want to keep in mind when we're doing a disc arthroplasty versus an ACDF is really gentle with the soft tissues. So minimizing use of Bovi. It looks like we're not going to be able to see much of anything here. But minimizing use of Bovi, really did very, very minimal drilling. Some people will do no drilling whatsoever, use only Kerrisons for their posterior lateral decompression. And one thing to keep in mind when we were putting our trial down, you can have, especially over at the posterior lateral aspects of the uncinate joint, there can be some bone there that will block you, and that's an area you want to keep in mind, especially on the caudal vertebra, most posteriorly. So again, we can't see a whole lot there. Let's go ahead to the trial.
That's a 17 by 14 trial.
So in this device, we've got both 6 and 7s. There are 2 different approaches to how people want to put these in. Go ahead and give us a shot there. And go ahead back to mag if you would, so we get a better picture. Shot again. And I've got quite a bit of distraction on the pins at this moment, and you actually want to take that off before you do your final preparation of the trial. So shot there. And that is possibly a little bit on the small side, but it does have a nice interference fit here. So again, there's 2 different approaches. We could have been a little bit more aggressive with the kind of anterior osteophyte here, which would give us a better concurrence of the top of the trial. But one thing that we can see is this has a nice hole in it. Give us a shot there. That we can know our orientation. And so if you look at the relative angle of my trial to my pins, I knew that they were a little bit off center. And so I can use that adjustment here. I can see that I've got nice facet joints laterally, and I've got a nice round hole. And so that's going to tell me that I have a pretty well-centered device. So give us a shot again. Okay, so pretty nice and circular there. I might even take a little bit more. Shot again. Going back the wrong way. Shot there. So this device as well, you can take the handle off and then come to an AP. And that will also give us a nice view as to where the implant will sit. So possibly a little bit off to one side. And again, I can adjust that. I really want to see that round hole in the center. I'm going to open this up just for viewing sake. Shot there. And so that, again, it's not perfectly aligned with the fluoro, but you can see that that hole in the center is pointed directly at us, and so that's going to give us a nice placement of the actual disc. So come back to a lateral, please. All right, so Sven, you want to take the trial, or I'll take the trial out, and then we're going to give you the actual cutting guide. And so relax here. So I'm going to close this because I want to have good interference of this trial, and so we know that we're actually cutting enough bone when we put this down. Okay. All right, so go ahead and take that for me. I'll put your retractors in here. One of the nice things about this device is there's no upwards and downwards. And so if you remember, we needed a little bit of this in order to be appropriately lined up. Give us a shot there. Okay, and you can see that nice circular hole. So that's going to mean that we're pretty well lined up. Okay, I'll go ahead and knock that down. Tap, 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 give us a shot. Keep going. Okay, and then hold on one second. You can see that you're starting to go a little bit oval, so you know that you may be deviating from the path we wanted. Shot there. And shot again. That's better, go ahead. Go all the way back. All the way back, keep going until you're right at the posterior aspect of the vertebral body. Shot. And that looks pretty good. I would adjust your hand a little bit, cephalab like that. Couple taps. Good. Okay, and then I'm moving this cadaver, so that's not helping our fluoro shot. Yeah, it moves all around. A little bit less challenging in a real patient. Shot there. There we go. So now we're going to use our back slap. I'm going to try and hold him as still as we can. Okay. And again, this device, go ahead. Sure. So you can, here's our device, and go ahead and grab that. Just going to plug it in. No up or down on this device. Mm-hmm. And it comes right out. Okay, and so directly visualize what you want to see. I'll give you some retraction on this other side. Mm-hmm. And then, again, you should be able to see it pretty well where your fins are, but we can check on our lateral shot. Okay, looks like you're in the appropriate orientation. And then go ahead and hammer that home. Go halfway back, take a shot. And again, we're going right down those pre-cut trajectory. So hopefully it goes in. Okay, hold on, stop there. Shot. All right, and that looks pretty good. And so at this point we can, okay. And shot again for us. All right, now we've got our disc arthroplasty. So again, most of the traction's been taken off of this. And some people would even recommend cranking down on it so that those fins really bite nicely when you take the inserter off. That's not a problem for us in this situation. All right, we'll take that pin driver. Go ahead and pull that pin for me, please. I'll take the retractor. Good. Good. One more time. It's coming out. It's free. Okay, just a final shot there. Okay, and one of the things we want to look is our facet joints in the back. We haven't put on too much and over-distracted them. I'm happy with the way that looks. Come over to an AP, please.
Hey, one second. Stay in the lateral. Amir, could you try to do a quick live fluoro and just flex the head and see how this kind of compressible disc moves?
All right, so go live.
That's very nice. And how high is this disc placement again that you put in there? Is that a 6?
So we use the 6. I think I could have gone with a 7, but again, that's a lot of patient or surgeon preference. Some people like to use the maximum possible. Some people like to use the minimum. And I would say we're a little bit off here towards one side. But again, we don't have the best landmarks because our cadaver's moving all over the place. Really want to be perfect with those pins. You can actually see how those pinholes are very nicely placed, but we're just off a little bit. But
I think it looks very nice. You had a nice foraminal decompression. Is this implant keyed off the posterior vertebral body just like other devices?
yeah, like most of the other disc arthroplasties on the market, this is going to want to sit right on the apophyseal ring. So when putting in my trials, I wanted to maximize that anterior posterior without being too big, but getting enough coverage to get it on that strong bone to minimize the chance of subsidence.
And to your feeling, I know you use many other implant manufacturers for this. Did you have to remove more end plate to get this down, or was this pretty similar to the others where you can preserve mostly end plate?
For this case, again, I feel like the most important part is the kind of posterior lateral aspect. A lot of times that bone can get very hypertrophic and kind of come inwards. You may think that you have enough space anteriorly, but on all artificial discs, I feel like I do have to take a little bit of that posterior lateral aspect of the end plate to get it to fit nicely.
That is really quite beautiful. So thanks so much for your expertise and beautiful demonstration. And I think that's very, very helpful also to see how nicely it went in, but also how it moves.